Thank you for this opportunity to talk today. My name is Maxine Tran. I am the academic lead for the Specialist Centre for Kidney Cancer at the Royal Free Hospital. My remit is to talk about a novel clinical trial called NEST and whether it will lead the way in the management of small renal masses in the future. I'm going to start with some background into how NEST has evolved. I'll then go into a little detail on the study design, and I'll finish off with what has been achieved so far and the future directions for NEST. So first, what is the unmet need in the management of small renal masses? I think we still need good quality level 1 evidence to help guide us in the clinical management of small renal masses. The standard acceptable treatment is obviously a robot-assisted partial nephrectomy. And although this is now considered almost routine, I think it has to be remembered that this is still a complex procedure. It requires a robot surgical system, a trained robot theatre team, and specialised training for the surgeon. Most patients stay on average a 2-night hospital stay with a 2 to 4 week recovery period. And published reports show an average complication rate of around 28% with a 7% positive margin rate. Alternative treatments for small renal masses obviously include ablation, and the various modalities of which Dr. Miles Walkden is going to discuss in more detail in the next talk. For the purposes of my talk and for the relevance of NEST, I'm going to concentrate on cryoablation. This is a percutaneous procedure performed under general anaesthetic in the UK. It needs specialist equipment and also specialist training for the interventional radiologist. However, recovery is quicker and there seems to be a generally lower complication rate. And obviously, active surveillance, at least initially, is also increasingly being used in the management of small renal masses, even more so over the course of the last year with COVID prioritisation of surgical need. So other clinical trials in small renal masses have been attempted. We have all heard and know about CONSERVE, which looked at partial nephrectomy in the era of mainly open surgery compared with RFA or cryo, and SURAB, which looked at cryoablation versus active surveillance. More recently, there has also been a trial registered in Denmark looking at robot-assisted partial nephrectomy versus cryoablation, and this was proposed using a conventional RCT design. This has since been withdrawn, citing logistics and lack of funding for the withdrawal. So NEST is a feasibility study, the main aim of which is to determine whether an RCT comparing NEphron-sparing treatment can be done. So the question is, can we recruit and can we retain patients to this study? And the objective is to use the results to inform the design, the sample size, and outcome measure for a definitive multi-centre prospective trial. Secondary objectives include health-related quality of life measures and standard clinical outcomes, which include complication rates, blood transfusion, ITU admission rates, and renal dialysis requirements, etc. We will also perform an exploratory cost analysis comparing partial nephrectomy versus cryoablation. So due to the known recruitment challenges associated with traditional RCTs, the NEST study uses an innovative cohort-embedded RCT study design, which incorporates a 2-stage consent process. The first stage is when eligible patients consent to long-term follow-up, completion of questionnaires, biobanking, and the future randomized invitation to consider new interventions or tests. The second stage is when the eligible participant is then randomized and invited to consider the intervention or test which is under question, which in this feasibility study is cryotherapy. So this is a schematic flowchart of the study design for NEST. So all patients with solid kidney mass that's less than 4 centimetres in size are invited to participate. And they are asked to consent for long-term follow-up, the completion of questionnaires and patient-reported outcome measures, and biobanking, and the future randomized invitation to consider new intervention or tests. If they consent, they then form part of this cohort of patients, from which we will identify eligible patients that are eligible for either cryoablation or partial nephrectomy. And these are then invited randomly on a one-to-one basis to either consider cryoablation or to continue on the standard treatment arm, which would be partial nephrectomy. Those invited to consider cryoablation can either accept the invite and have cryoablation, or they can decline the invite and proceed along standard treatment, which would be partial nephrectomy. All eligible patients are then included in the intention to treat analysis. However, all patients, regardless of whether they are eligible for randomization and whether they accept the invitation or not, have already consented for long-term follow-up, patient-reported outcome measures, and biobanking. So the study design advantages mean that because the patients are within this cohort, long-term and short-term outcomes can both be studied. And because we have this long-term outcome, we can study the natural history of the condition. Patients are more likely to consent for the second stage because they know which treatment they are agreeing to. The non-disruptive nature of the trial means that patients receive care in a routine healthcare setting, so they do not need to visit a clinical trials facility, for example. And we can also measure the acceptability of the intervention, and the nature of the cohort means that the addition of future interventional arms is allowed, and so further RCTs can be embedded into this study cohort, subject to separate ethics approval. So the funders of NEST are the NHR Research for Patient Benefit Programme, and the sponsor and coordinating centre is the Royal Free London NHS Foundation Trust. The target for NEST is to recruit 200 patients into the cohort, and from the cohort, 50 of these patients will be recruited into the embedded RCT with 25 patients in each arm. NEST was opened on the 13th of May 2019, and the first patient was recruited into the cohort about 2 weeks after that, and a further 2 weeks later, the first patient was recruited into the embedded RCT. Obviously, COVID-19 has disrupted the NEST trial, and there has been a pause on study recruitment during the first lockdown, and there has been disruption during the second and third lockdown. However, there has been multiple achievements since NEST has started. The protocol has been published in BMJ Open. We have presented the study design at the IKCS in Miami in 2019, and we've been invited to advise on the clinical trials planning meeting at the IIH just before COVID in January 2020. The study itself has also been cited about 8 times now in other manuscripts, so it is gaining international interest. The NEST feasibility study team comprises a varied research team of motivated clinicians and academics, such as a statistician, clinical trials expertise, a qualitative researcher, and a health economist, and 2 very motivated and enthusiastic patient representatives as well. So, returning to the question of whether NEST will lead the way in the management of small renal masses in 2030, I mean, who knows? The trial is still ongoing, but I'm confident confident that we will complete recruitment in the next few months. And so in the very least, I think we will be able to determine whether such a trial can be done using such a study design. I think that as all patients have consented for long-term prospective follow-up, I think we will get very insightful information into the natural history or natural clinical pathway for a patient being diagnosed with a small renal mass. And the actual design of the study, which allows the further embedding of new RCTs, means that I'm very hopeful that even if it does not lead the way in the management of small renal masses, it will still have a very important role in the narrative of the management of small renal masses in 2030. So with that, I'd like to thank you for your attention, and I'm very happy to address any comments or questions. Thank you.